I'd like to introduce Annie Portela. She was the keynote speaker we were expecting this morning, but because of technical issues, we weren't able to connect with her. So Annie, I'd like to introduce you. Maybe people who were watching before, they will have already seen you, but some of the new people joining us won't have met you yet. So Annie is a senior technical officer at WHO in Geneva. She has loads of experience, over 20 years experience working in maternal and newborn child health, with a particular focus on access for care for underserved populations and women, and also community participation in the design of health programmes. So Annie, without further ado, I'm looking forward to what you're going to talk about, and we'll see how many questions we get at the end. Well done. Good luck.
Thank you. We're going to try this again. This is a little deja vu now, but thank you for joining. And apologies for the hiccup this morning. Let me start by saying a big thanks to the organizers and how well they've handled the hiccup, maintained their calm, and helped me to maintain calm. So happy to be with you. This presentation, again, the idea wasn't that we talk about implementation research with this presentation, but rather take you through respectful maternal and newborn care. And we'll start by colleagues from SRH, Hediye and Oske, who lead the work in another department in WHO, and they'll give you some of the conceptual background about maternity care. And then we'll hand over to Emma Sachs from Johns Hopkins University, and she'll talk about integrating newborn and making sure that newborn is an integral part of respectful maternity care. And then I just want to quickly go over with you and leave you with some of the implementation challenges we've seen. And I hope my main purpose is that in your next sessions and as you participate throughout this conference, hopefully you can think about these challenges in light of implementation research and how you would address them in your upcoming work. So can we go to the next slide and to the presentation by Hediye and Oske?
Hello, this is Hediye Mertosh, and I'm really excited to be presenting WHO's research on respectful maternity care. So as many of you know, the issue of disrespect and abuse was really highlighted by the Bowser and Hill landscape analysis in 2010. This eventually led to the WHO statement on the prevention and elimination of disrespect and abuse during childbirth in 2014. And since then, there's been various ways to frame this issue and various terminology used, starting with obstetric violence in Latin America, and of course, as I just described, the disrespect and abuse terminology that initially emerged, which led to mistreatment, which is the terminology that WHO uses to describe this phenomenon based on the 2015 systematic review. And also evolved into respectful care, which is a broader concept that encompasses mistreatment during childbirth. And so the typology of mistreatment conducted in 2015 was 65 studies from 34 countries, including the following 6 domains. Based on this typology, WHO led the multi-country study on how women are treated during facility-based childbirth, given that there had been no global level effort to systematically define, measure, and prevent mistreatment. Therefore, the objectives were to develop and validate tools that can measure this phenomenon, but also to explore factors that are associated with mistreatment during childbirth in facilities. Phase 1 involved qualitative research to explore what constitutes mistreatment across the 4 countries in the study. The protocol has been published, and also the evidence from the countries. Phase 2 was the tool development and measurement phase. It was really a mixed method approach to develop 2 tools that you can see here, the labor observation form and the community survey tool, that are now publicly available online, and the methods are also published. So really the results were published in October 2019 on the measurement phase, and it was again, using the 2 tools, the labor observation and community survey tool, and it was really collecting data on women's experiences of mistreatment and also sociodemographic and obstetric history. And I'm going to briefly go over some of the results. So just an overview of the sample, approximately 2,000 women across both tools. In terms of some of the key findings, as you can see, this is the domain for physical, verbal abuse, stigma, and discrimination, which across both tools, and across 4 countries, you can see the results. And I just wanted to highlight the importance of timing. And so here we looked at the timing of when physical and verbal abuse occurs using the labor observation. And it was really between 30 minutes before birth to 15 minutes after birth that this peaked. And women were really at an increased risk for both of these phenomenon during this time period, which is critical to address. In terms of other areas, such as informed consent, across procedures we see non-consented care, with the highest being among episiotomies, both picked up by the labor observation tool and community survey tool. So you can see the results here. And in terms of consent and confidentiality, taking vaginal examinations, looking at vaginal examinations, over half of the women both reported and also were observed not to be consented or have their vaginal examinations conducted privately. And we saw that simple measures such as curtains were really are really key to prevent mistreatment and allow women to feel that they were private, given that women who reported no use of these measures were 3 times more likely to report lack of privacy. And also risk of non-consented care was seen among unmarried women and younger women, which brings us to the point that really factors associated with mistreatment include vulnerable populations, between vaginal examinations and also other areas of mistreatment, of the mistreatment typology. And so it's really important to tackle these key vulnerable populations when we're addressing mistreatment during childbirth. In terms of the evidence, we've been fortunate to translate some of our evidence to national recommendations on respectful maternity care in Guinea. Based on the published evidence from October 2019, stakeholders in Guinea came together to develop recommendations based on the findings, their national findings, and adopted them in their reproductive health plan. And this is really an exciting turning point to see research being translated into practical recommendations on the ground. We're also excited to be measuring mistreatment of women in the WHO EMRO region, a region where there's really limited evidence on this phenomenon. And so the occupied Palestinian territory is leading the effort in 3 regions, Gaza, Hebron, and Ramallah. The training was conducted right before COVID, and since then, however, we've had to amend. The data collection methods have been modified, however, the study is ongoing. There's a number of secondary analyses using the study that we're also working with our country teams and colleagues to work on. And this includes some analyses on newborn practices, such as 15 observed practices from the labor observation tool, and among many others. And next, WHO is really looking to reduce mistreatment of women during childbirth, and really to understand what interventions are needed. And of course, there's no one magic bullet, and so we're currently looking systematically on scoping, systematically looking at the evidence through scoping and systematic reviews to better understand this. I hope this was a great presentation. Thank you very much for your time.
Great. So a virtual applause to Oske and Hediye for orienting us. All those tools are available online. And now we're just going to pass over to Emma. Emma, just note the slides on the screen might be different from the last set you sent me, so beware. So Emma's going to talk to us about integrating newborn into respectful maternal and newborn care. You may be on mute.
Hello? I'm not on mute from my side.
I can hear you
can't
now.
hear me?
So I can hear you, so I'm hoping the rest of the world can hear the 2 of us. If any of the organizers want to say something so we know someone's listening to us, that would be great.
Yes, we can hear you.
There you go. Okay, Emma, over to you.
Thank you. And thank you again to the organizers for putting this together. Thanks to Annie for inviting me to speak more about integrating newborn into respectful maternity care agenda. I don't know who's advancing the slides. Can
Just say
someone
next.
advance? Next, thank you. Sorry, they're tiny and blurry, so I don't know what they say. So hopefully they're close to mine. I apologize for this. There we go. Thank you. So anyway, thanks again for everyone for joining and sort of taking part in this discussion about a really important topic. I think we can all agree respectful care sort of should include everyone who is seeking care at a health facility. And we have some anecdotal evidence that there's mistreatment of newborns or kind of negative experience of healthcare that newborns are having at health facilities, but there hasn't been as much attention kind of on the systematic research side. And obviously that's important kind of for the care of newborns and their families, and it may also be driving low utilization when the costs for seeking care are high. Next slide, please. So the terminology of respectful maternity care was always intended to include newborns as well as families and healthcare workers and everyone kind of participating in that maternity experience. However, as I mentioned, there hasn't always been the same level of attention to newborns. And part of that is because newborns have limited communication ability and depend on parents. However, we know that many women and newborns are cared for by the same providers in the same facilities, and that many of the rights are shared by newborns and their families. So not being separated is sort of both a right of the newborn to be with their parents and the parents to be with their baby. Similarly, the right of a newborn to have their legal guardian consent for their medical practices, a right of the parents to consent for the medical care of their newborn. Next slide, please. So you heard already about the typology that was developed for looking at mistreatment of women. I conducted a literature review a couple years ago to see if there were occurrences of mistreatment of newborns that fell into these categories. And unfortunately, there were in most of them. There were also additional kind of categories that we thought were important around legal accountability and around bereavement after a stillbirth or neonatal loss. So I think there's some more thinking to do around what these themes might be or how they might need to be expanded when we're trying to document kind of various experiences for newborns. Next slide, please. So there's quite a bit of ongoing research just starting out to try to build out some of the evidence around newborn experience of care. And a lot of it is around kind of what are the types of experiences and the prevalence of various types of mistreatment or negative experiences that newborns have, as well as are certain groups more vulnerable to mistreatment than others. These might be characteristics that are shared with the family, such as being poor or from an ethnic minority group, but they also might be characteristics of the newborn that are unique and independent of the parent, such as being female or being small and sick. I think there's some sort of difficult gray area around what might be poor quality of care that maybe everyone in a facility is experiencing versus some disrespectful and discriminatory practices, and that can be difficult, I think, to disentangle, but we're starting, I think, to try to talk about what those various aspects of quality look like. Very importantly is how do people conceptualize newborn experience of care or mistreatment of newborns, and that includes kind of mothers and families, as well as the providers themselves and other people that work in this field. And so I think understanding that will help us develop what are the domains and how much do they overlap with those developed for women. There's an ongoing scoping review to look at tools that might be available or components of tools that ask specifically about newborns that I think will also help us not just standardize our measurement, but also will help us build the framework into something a bit more complete that can help us understand this for newborns. Next slide, please. So you already heard about the WHO study on how women are treated during facility-based childbirth. And one of the components was a labor observation tool, which occurred in Ghana, Guinea, and Nigeria. Next slide, please. And within that observation, we were able to get data on 15 newborn care practices that occurred during the first 2 hours after delivery. So these include things like immediate skin-to-skin care and breastfeeding indicators, a number of kind of recommended practices. So we can see the prevalence of how many newborns are receiving the recommended sort of evidence-based care. We also are able to see some practices that are occurring that are not evidence-based or that are potentially harmful. These include the newborn being separated from the mother, routine suctioning, slapping the newborn, and then maybe some of the more rare but serious events, such as the newborn being left unattended or refusal to provide care due to inability to pay. Next slide, please. So I hope that gives a small taste of some of the things that we're working on to try to build sort of newborn experience of care and treatment of newborns into this agenda. And I think there's quite a lot of work to be done. So this includes developing tools that can be used at the regional and national level. And in order to do that, we'll need sort of global tools as well as a level of contextualization. So quite a bit of sort of qualitative work also needs to be done to understand how these might need to be adapted for various settings. And that includes those with additional needs such as humanitarian or crisis settings. I think there's a hugely important piece of work that's also just starting around the types of support that healthcare workers need in order to provide quality care to mothers and newborns. I know there's a lot of providers on this call, and I think, you know, the providers themselves want to provide high quality care. So this is sort of a partnership that we want thinking about. How can providers be supported to be respected themselves and then provide the most high quality and respectful care to the women and newborn who are seeking their services. I think there's quite a lot of continued advocacy and harmonization that we can keep doing. It's been wonderful to be able to work across sort of those that work in newborn, pediatric, and maternal care. And I think we all see that the agenda will be stronger the more inclusive it is and the more everyone can contribute to it. I think, was there one more or is that it?
That's it, Emma. Over to me.
That's
Thank
it.
you so much.
Thank you very much.
That was great. Thank you. Stay on for questions, please. So now I'm going to take you through some of the implementation challenges. And again, I've done several different implementation research linked to respectful care or components of respectful care. And so also in working with country partners, we've heard a lot now that countries are keen. I mean, the conceptual part is so important and the measurement part is so important, but countries are really keen to move on to implementation. So next slide, please. The first challenge is probably, or one way of moving forward is making sure that respectful maternity care is integrated into quality of care processes. And you may remember some years back, WHO launched the standards for maternal and newborn care and a vision of quality. Next slide, please, where particularly starting with for maternal and newborn health, it gave the equivalent to the provision of care as it does to the experience of care, with effective communication, respect and preservation of dignity, and emotional support being highlighted as three of the standards. And again, this is quite important. And what we've seen now, the struggle is working in quality of care is how do you have providers and managers equate what is sometimes deemed the soft skills and equate them with the same level of importance as they would give to these other more clinical skills. And that's probably quite, when in a quality of care process, of course, we don't do everything at once. And when we're designing our first steps and highlighting what would be the first measures to tackle, again, how does a system help incorporate and make sure that experience of care is considered in those priorities? And later on, we'll talk about some things that might help with that. Can you just go quickly to the next slide? I just wanted to highlight that this same experience of care has also been highlighted in the quality of care for children and young adolescents. And again, slightly different, but the same components of effective communication and meaningful participation, respect, protection, and fulfillment of rights, and emotional and psychological support. And the next slide. And you'll see now in the recently launched standards for quality of care for small and sick newborns, again, embedded in there is this respectful care. And I just wanted to highlight that, again, so embedded in your quality of care, that's a first to tackle, that's considered a priority. What we've really been struggling now is with the measurement. As you've seen from the past slides, a lot of the measurement has focused on what is mistreatment, what is abuse. A lot of the measurement is being done through research and scales. And so when we get to the quality of care processes, it's been quite a struggle to help countries identify those indicators and those measures that are already embedded in their system. So this is something, again, a challenge we need to think about and work on. How can we make this more part of their system? Or are we going to always be doing special studies? Next slide, please. So similar and related is the challenge of making sure respectful care is integrated into the normative work. Next slide, please. And one way, in WHO, we've started that, and I feel has been the tipping point or a change point, was starting our normative work from the perspective of what women want. And the antenatal care guides was a good example of that. I mean, research was done to pull together what is it that women want and expect from antenatal care, and then that helped guide and was included in evidence to decision framework. So not just looking at the results of is any intervention effective or not, but what are some of the important women's values and providers' values that need to be considered as well for the different interventions. Next slide, please. That also came up clearly in the priority questions for childbirth care. And again, this paper led by the brilliant Sue Down, focusing on matters to women, again, really helped to crystallize that women want a positive childbirth experience that fulfills or exceeds their prior personal, social, cultural beliefs and expectations. And there we just put some of the keys that came out from the research. Again, things that women want out of it. And that is so linked to respectful care, is responding to what she deems as priority. Next, please. So again, how do you operationalize respectful care for childbirth? In addition to avoiding mistreatment, abuse, some of the positive interventions, ensuring respect and dignity, clear communication by staff, a companion of choice during labor and birth, pain relief strategies, and mobility in labor and birth position of choice. Some of them providers are more comfortable with. Others, providers really feel are not their skills and maybe need more support to. And even looking at companion of choice, and we'll come to that separately in a minute, providers have their own barriers to implementing these types of interventions, and how do we find those barriers and help to address them. Next slide, please. So effective communication, again, is really a cornerstone for respectful care. I just put some tips there about what effective communication should include. This was included in the recent intrapartum care guidelines. But this communication between providers and women in labor, women during their stay in the facility or during childbirth care, using simple, culturally acceptable methods is what's recommended. And next slide for this one, just again to summarize the 4 recommendations that came out in the recent child intrapartum care guidelines, and that to me really, embody respectful maternal care and maternity care and the important interventions. Next slide. And I just want to take a quick focus on companion of choice during labor and childbirth. In the next session with Tina Lavender, I'll be talking a little bit about the implementation research we did in 3 Middle Eastern countries, Syria, Lebanon, and Egypt, to help implement companion of choice. It seems like a low-hanging fruit, but again, it's an intervention that providers, women themselves, have a lot of conceptions about. Can you just go to the next slide, please? Today, we've launched a web story on the WHO site, so please go to the site and find highlighting a new evidence brief, an evidence to action brief that came out. There's the link, and I encourage you to look at it. It includes a logic framework that we hope will help support implementation, but also help for advocacy and better understanding some of the key points. And the final point I want to make, next slide, please, and this came out a lot in the previous section, and probably Sally talked about it in her overview presentation this morning, but this whole idea of co-production. And again, respectful care, implementation research, we just cannot do it without embedding co-production into our processes. And again, it's something that neither researchers or neither implementers are very comfortable with. And learning to dialogue, learning to understand, and appreciating different knowledge and helping to put that all together is really one of the key implementation challenges. So, there's been different processes. For example, the White Ribbon Alliance and the campaign and listening to what women want around the world. It's just so important that we start with understanding what's important to women. Next slide. Also, in our work for WHO, for the Quality of Care Network, again, we've really struggled. How do we make this part of stakeholder and community engagement, hearing providers, a core part of any quality of improvement process? And the Quality of Care Implementation Framework does include stakeholder and community engagement as one of the key components. And when as we're working with the countries involved in the network, a lot of them said to us, we really feel we need support to bring forward this component. So we've developed a module, and with UNICEF and other partners, including Save the Children, World Vision, and other partners, we hope to bring it forward and be able to make that, just a really key step in quality improvement processes. Next slide, please. I talked about respectful maternity care and the charter and the importance of that, hearing women's voices, next slide, please. Women understanding their rights. The charter is so helpful for that, so that women, families, communities, and providers can see, what are women and newborns' rights, so that they know them and can help to protect them. And I'm going to go to my last 2 points. Next slide, please. And as passionately advocating to you to make sure women are heard, I also want to passionately advocate that you make sure providers are heard, and particularly midwifery and nursing providers when we're talking about respectful maternal care. As you know, this is the International Year of the Nurse and Midwife. Globally, 70% of the health and social workforce are women, and many of them are nurses and midwives. Next slide, please. They have to have a seat at the table. There were 2 efforts. One was a systematic mapping of the literature to highlight what prevents quality midwifery care, and hear from midwives what are some of the barriers they face. I think if you click again, something else should appear there. And there was Midwives' Voices, Midwives' Realities, a global consultation on providing quality midwifery care that captured midwives' perspectives on the challenges they face. Next slide, please. When we looked at the findings and put them all together, again, we demand respectful care, or we expect respectful care. We respect quality of care from a labor force that is truly challenged. And that's not meant to be an excuse. But again, if we hope to address quality of care and respectful care, unless we work with providers, unless managers work with providers, unless the research team, reaches out to providers and captures their perspective, we will not address some of the main barriers they face. And it's a difficult interplay of social factors, economic factors, and professional factors, and really embedded in gender inequality that makes for a difficult situation often for providers to, again, provide the care that we expect from them. I just want to take one last point on resilient health systems. Next slide, please. And I know the last session talked about COVID. Next slide, please. And again, as we are working with services, how do we support countries in maintaining essential health services for women and newborn? And as we're supporting them, again, COVID was difficult for health systems. First effort is to stop the infection, and but nonetheless, how do systems with all these demands help to maintain the services for these key populations, and in maintaining those services, not take shortcuts on some of the key components of respectful care. We've heard stories and read stories about women and newborns being separated and companions not allowed, and other what would be violations of respectful care. Again, how do we make sure that this is maintained during these situations that we're working closely with countries to address that? So I'll stop there. I hope I've given you food for thought. As you think out, next slide, please, just to say thank you. As you think about your implementation research and needs, I hope this helps to stimulate you. So over to you, Terry, and thank you again for inviting us.
Oh, thank you, Annie. I think for me, it makes me remember the conversation we had a few days ago, because it was the first time we met, and I think I should say first that I am actually a nurse and a midwife. I've worked mostly as a midwife. So, for me as a midwife, birth is the most joyful time for a parent, for a couple. And yet as a midwife, I would like to be able to facilitate that. But when I listen to my colleagues in many countries around the world, they tell me that there are no staff. There may be one midwife or one nurse midwife on duty on a night shift, and they're looking after 10, 12, 20 people in labour. So the system doesn't seem to allow or to facilitate care providers to be able to provide good care sometimes, because if you are stressed yourself, you haven't had a tea break, you haven't had your salary, there's no running water where you work, there's an electricity cut. The build-up of frustration and anger in the system that you're working in, how do we actually help and support our colleagues to be able to provide better care, provide this respectful care when they feel disrespected themselves? Yeah. Again, so Sally's words, and again, listening to Jane and Imelda in the previous one, co-production, planning, again, if we're going to use implementation research to address these kinds of barriers, I think planning came out heavily, and one of the things I wanted to add about it, it's proper planning, it's having the proper team, it's having co-production, it's also this learning component that was really important that I think is really difficult for researchers to accept. I think a lot of times researchers are used to having a protocol and following the protocol, and this idea of not having, being able to change and incorporate learning and improve what I'm doing is difficult. But really this part about I cannot address the barriers unless I work with women, with families, and with providers to better understand the barriers that are, again, social, systemic, economic, cultural, and all of them have to be addressed if we're going to achieve successful implementation. Now, we've just received thank you. So we've just received a really interesting question from Veronique. Really sort of saying we need some success stories as well. We know the problems, we've known them for a long time. All our colleagues know them who provide maternal care. WHO knows them. This has been around for such a long time. But do we have success stories where it works? Can we start sort of disseminating the lessons learned, trying to see what works in one place, can it work somewhere else?
This is why I found it really important that I agree with you, Veronique, and I think all of us are frustrated that appreciate the need to start with identifying the problem, but really frustrated about moving on to the implementation. There are success stories, and it's time that we start compiling better, sharing them better in terms of scaling it up in a country and also moving to another context. Again, a lot of times implementation research can provide the best venue for doing that, because you do have to find what are the contextual issues, how do I work with them, and then how do I address them to scale up. But I definitely agree with you. Emma, I don't know if you'd like to say anything else to that point.
Just that I agree. I mean, I think that should be sort of part of our data collection, right? And part of our framing is to not only be looking for those instances of disrespect and mistreatment, but also thinking that the absence of that is not necessarily the same as respectful care. So what is it that's important to families, and being able to collect some of those positive stories, not just from families, but from health workers. What is it that enables the health workers to provide the best care in order to support them as well? I think those are really important sort of research priorities going forward.
Yeah. And from health systems, because again, it's not just, there are places where implementation has been successful. And again, we learned a lot in the implementation research on labor companions. So it's not just a matter of, it's at all levels. The individual woman, her family, and the provider, what are their positive stories, but also what are some of the system stories where they've been able to implement and scale up. And again, kangaroo mother care work, we had work in Ethiopia and India, and I feel that's a respectful maternity care story. While the focus was on implementing kangaroo mother care, the effort requires that the mother, the woman, and the baby are together, and the mother is treated throughout the baby stay in the facility with respect and supported to better take care of her baby. And that is that's a norm change for a lot of places in after a baby's born with problems, and how we interact with the mother thereafter. So again, many dimensions to this.
So we've had quite a few questions about the support that we give to staff and how we teach, how we empower them to be able to give emotional support to women, but also for themselves. And I think we've talked about this quite a lot, but there's been another question from Antenna in Melbourne, and he's asking, really, what initiatives does WHO have to promote the rights of midwife while also helping them to be able to provide respectful care, to train them well? What else can we do to help the people on the ground who want to provide this care?
Oh, I'm so grateful to this question, and so sad that my colleague Fran McConville is not on the line, because I very much suspected this would come up, but she was unable to join us today. And as I said, this is the year of the nurse midwife, and I feel like WHO and UNFPA together with ICM and ICN are really doing a lot to help support midwives. So not just only in advocacy, but that is a big part of it. Fran would tell you about a midwifery framework, improving the quality of education of midwives so that they have the skills they need, more dialogue, again, involvement of midwives and giving nurses and midwives a voice at the table. As you know, Elizabeth Ito, who is our senior advisor to Dr. Tedros, was appointed in the last 2 years. And again, the whole purpose was for highlighting the needs of and the importance of midwifery and nursing in health, and the importance of these providers in the health workforce. So I'm not doing justice to the response, and Fran will be very upset with me. Apologies, she's not here, but I will make sure that later on we share the link and see about how we can have ongoing conversations, because there is really a lot going on now. It's been recognized as one of the key the areas we've been negligent on, and unless we better support midwives, better support them in their competencies, and have policies that support them in doing their job, and again, all the different barriers they face in terms of safety, economics, gender, we kind of expect to see the improvements we're asking for.
I think that's really important, and I think, as you were saying, it's about how we actually help nurses, midwives become leaders. That they actually promote their own profession, that they have that voice, at a much higher level within countries, at a national level, to be able to say what it's really like on the ground floor, and to be able to say what they need to be able to do their job better. So I'm really hoping that it's a really shout out to everyone, really, that that we get behind the workforce, and we really help them to be able to do a better job, because no one goes to work wanting to have a bad day. No one goes to work thinking, right, I'm going to shout at this person, or I'm going to do this. It's that day in, day out struggle to be able to do your job, to actually get to work, then to, you're faced with so much to do and so little resources to be able to do it. So it's about how we manage that as well, because I think, so many people, or the midwives I talk to, they really enjoy their job. When they talk about being a midwife, they are so proud of being a midwife. And it's about how we actually help them to be able to provide better care, as we've been talking about. So I'm looking at the other questions, and one of them is about the gaps between, what about when we're trying to integrate maternal care and newborn care? What are the gaps, and how can we actually bring it more together so that we are working as a team?
Emma, do you want to start, and then I can add, or?
Sure. So I think that's, a good question in thinking about sort of how do we tackle this, right? And I think the way that a lot of us who've been working on this see this is just expanding the existing agenda, right? So not wanting to create kind of parallel initiatives, but really thinking about the massive amount of overlap that there is between sort of maternal and newborn care in this particular time period. I think some of the, I wouldn't call them gaps, I would say some of the unique challenges around newborn treatment and experience of care have to do with the kind of limited communication ability of newborns, which isn't no communication, but right, newborns not being able to verbalize their needs and consent for their care in the same way that most, adult or adolescent kind of females can do. So I think thinking about those challenges as far as making decisions in the best interest of the newborn, and what to do when there are conflicts, either between sort of parents or between the parents and the health worker, et cetera, are important. I think we need to keep those in mind, recognizing that it's a smaller kind of percentage probably of the sort of, I don't want to call it amount of work exactly, right? But that in most cases, the needs of the woman and the baby and the family and probably the healthcare worker also are well aligned, right? So I think that can really be the vast majority. And then there are, I think, some additional unique challenges of newborn care that we do need to acknowledge and sort of continue working on, even though I think those are more rare. There are some kind of difficult pieces there. Annie, maybe you want to add more to that.
Yeah, I think you covered it well, and I mean, the movement started maternity care and the focus on childbirth care, and again, it was always intended that newborn be integrated. And then as we moved from looking at measurement into implementation, we did realize that somehow, though there was just this look at more, the mother and childbirth, and so again we're expanding. I'm just going to refer again to working with kangaroo mother care. It also, working with newborn care, and in particularly small and sick newborn. Again, if you look at the standards and what's come up, there are specificities for the newborn that need to come out. And two, it's not just the moment of childbirth. Again, it's a vision of how we treat the woman and baby and family throughout their stay in the facility. So it's not meant to be, I have respectful care for childbirth and then my newborn's sick, so I have to lie in a hallway, to be able to see the baby. It's, the whole time they're there, and any interaction a health system and a health service and a health provider has, that the components of respectful care for the mother, for the baby are incorporated. But I think you gave a really complete answer, Emma.
Well, I'd like to thank both of you. Our time has just about come to an end. I think